And these guys are my true friends, George Kirtley, Kenny Hamlet, Mike Apper, Alvin Neff, my partner Gerard Lemongello, and Dean Bafiatis, who unfortunately we didn't have a picture of. But these guys are all the senior instructors, and you know, they're a great group of guys, and I think it's a phenomenal program that we put together. So moving on, what we're going to talk today about is condyle of position, but more specifically centric relation. And what is centric relation? Well, there's a study that was done recently where at 7 dental schools, when they polled the students and the instructors about the definition of centric relation, that there was so much confusion that they couldn't get a consensus on what centric relation was. So how can they really find or record centric relation? What Pete Dawson says in his book, and this is his definition that we got out of his book, is that centric relation is the relationship of the mandible to the maxilla when the properly aligned condylar disc assembly are in their most superior position against the eminentia, irrespective of tooth position or vertical dimension. At the superior position, the condylar disc assembly is braced medially. Thus, CR is also the most midmost position. A properly aligned condylar disc assembly in CR can resist maximum loading by the elevator muscles with no sign of discomfort. And, you know, that's a pretty big definition, so what we try to do is break that down, and what Pete is basically saying is that centric relation is a joint-based position, that you can find this independently of the teeth. Okay, you can find at any vertical dimension, and the teeth do not have to be in occlusion, that it's a bone-braced position, and it's a repeatable position, and that's important to be able to find this position over and over again when you're taking your bite records. It's a physiological endpoint. The jaw doesn't always function here, but it needs to be able to go there freely, and the only way that it can go there freely is through coordinated muscle movements. And what do we mean when we talk about coordinated muscle movements? I'm going to show you a little bit later that we have our elevator muscles and we have our opening muscles, and only through smooth coordination of those muscles can we get to CR freely. Now, what I did here was take my old dental school skull and with some articulating paper, putting the condyle in, showing where the condyle should seat. And basically, you can see that the medial pole is what is braced against that thickened bone, that buttress of bone there. Now, the condyle is free to move here, and the medial pole is what rotates around this midpoint. The lateral pole actually works in a windshield wiper fashion, actually sweeping that synovial fluid over the head of the condyle so that the condyle can move nice and smooth in this glenoid fossa. Frank Spear takes the definition of centric relation, and I think he really simplifies it. And what Frank says, it's the position of the condyle when the lateral pterygoid muscle is relaxed and the elevator muscles contract with the disc properly aligned. So Frank is taking this and making it more of a muscular definition, because the muscles are the ones through coordinated movement that can bring the condyle up into the glenoid fossa where it's supposed to be sitting. So let's look at the muscles a little bit and understand what each of the muscles do. The muscles of elevation or closing muscles, first we have the masseter muscle, and then we have the temporalis and the medial pterygoid. These all help elevate the mandible and are responsible in clenching the teeth together. In this diagram from Bite FX, you can see that as the mandible starts to close, the temporalis, the masseter muscle, you can't see the medial pterygoid because it's on the inside of the ramus, all turn red as far as showing that they are contracting. These are graphics from Bite FX, which happen to be a wonderful program. It's a great tool or instrument that we use here in our practice to help educate our patients on bite issues and TMJ problems. So I want to first of all thank them for allowing me to use their movies in our lectures and our programs. Here's a graphic showing the medial pterygoid, which you couldn't see in the Bite FX video, which runs on the inside of the ramus, and with the masseter along the angle of the ramus will form that pterygomasseter sling. So the temporalis, the medial pterygoid, and the masseter muscle are all responsible for elevating the mandible. As far as the positioning or opening the muscles, the lateral pterygoid is the main muscle that is responsible for this. It's responsible for protruding the mandible, it assists in rotation of the condyle, and it has two parts, a inferior border and a superior border. The inferior border is connected, or the inferior belly is connected to the head of the condyle, and the superior belly is connected to the meniscus. And they work in conjunction with each other so that the meniscus can stay in a close relationship with the head of the condyle. So if we show the Bite FX video, and we're going to play it back slowly again, that as the mandible starts to open and translate, the inferior belly of the lateral pterygoid is going to contract and turn red. As it gets to maximum opening, you're going to see that the superior belly is going to start turning red because it's holding the disc on the head of the condyle so that the disc doesn't slip distally. So we'll replay that again so that we can see that picture. Again, opening, the inferior belly contracts, and as we start to close, that the superior belly is contracting. Now then you have other muscles of mastication, which are the suprahyoid group. You have the stylohyoid, the geniohyoid, the digastric, and the mylohyoid. And all these help in depressing the mandible and in opening. And what you just need to realize about these groups is that they are opposite or antagonistic of the elevator muscles. Okay? Again, in the schematic, you can see as the mandible starts to open, the lateral pterygoid is contracting, while the masseter, the temporalis, are blue, which means they're relaxing. And now as the mandible starts to close, that those muscles, the temporalis, the medial pterygoid, and the masseter start to turn red. And here, with coordinated muscle movement, and we'll continue to play this again, as the mandible opens, the inferior belly of the lateral pterygoid will contract, the masseter, the temporalis are all relaxed. Now we get to maximum opening, and the mandible starts to close, the temporalis, the masseter, the medial pterygoid, and the superior belly of the lateral pterygoid, which is holding the disc, is going to be contracting. In coordinated muscle movement, when we're in centric relation and the condyle is lining up in the most superior position, we can see that the meniscus is properly positioned on the head of the condyle. You have in the yellow area the bilaminar zone, which is the retrodiscal tissue, but the darker orange is the meniscus. And as the mandible is opening, the inferior belly of the lateral pterygoid is contracting. I'm going to play that again. I'm just going to go back. Is contracting. And now when we get maximum opening, the superior belly starts to contract along with the temporalis and the masseter. Now what happens when we're not in centric relation? Well, what happens here, because something is bringing the condyle out of CR, and most of the time it's the teeth that are doing that, okay, because they're not in a position that is corresponding to the condyle being in the most superior position, then the only way that the condyle can be out of centric relation is if the inferior belly of the lateral pterygoid is contracting and moving it out of position. So if the teeth are in maximum intercuspation and interdigitating and it's not corresponding with centric relation, then the inferior belly of the lateral pterygoid has to be contracting. Okay? Now, if you're in maximum intercuspation and you're not corresponding with CR and the patient starts clenching their teeth, what happens is your elevator muscles are contracting, your lateral pterygoid muscle is contracting to hold it forward, and now you can possibly get muscle spasm, fractured teeth, headaches, and all signs of instability. So if we play this again, we can see there's coordinated muscles that as the lateral pterygoid is firing, the elevated muscles are starting to relax, and then as the elevated muscles contract and close the mandible, the inferior belly of the lateral pterygoid relaxes. But in incoordinated muscle activity, everything is firing when the teeth come together because it's not corresponding to the condyle being in the most superior position. If we look at side-by-side comparisons with the Bite FX, you could actually see everything firing in the lateral pterygoid, both the superior belly and the inferior belly, because the condyle is held down and forward and it's not in its most superior position. Realize that unless the condyle is in its most superior position, the inferior belly of the lateral pterygoid cannot be relaxed. It has to be contracted because that's the only muscle that pulls the condyle down and forward. So the key point of all this is centric relation is the only jaw position, okay? It's the only position of the condyle that you can build an interference-free occlusion. Any other occlusion that you're building that is not corresponding to the condyle being in CR, then you basically are getting muscle incoordination. Now, whether that becomes a symptom to your patient, whether they get muscle headaches or pain in their teeth or fractured teeth, depends on individual to individual. The greatest thing about dentistry is about 80% of our patients adapt to anything that we do, but it's that small percentage of population that could be anywhere, up to 20%, that if you don't build their occlusion properly, then you're going to see signs of instability and pathology in their occlusion. So let's look at some of these interferences to centric relation. Now, what happens if we build the occlusion, okay, and it doesn't correspond to CR, then what happens is you get a hit and slide. That the lateral pterygoid wants to avoid that interference, which is usually a back tooth, and it's going to start to close in a arc of closure to avoid that prematurity, and it's going to close forward, and as it closes forward, it's going to bring the condyle down and forward. Okay? Now, here's another schematic from Bite FX. If you build your maximum intercuspation and it's not in correspondence with CR, then at night when the patient bruxes and the elevator muscles want to seat those condyles because their forces, vectors, are going up to put the condyle in the most superior position, that as you start to brux and go backwards, you start fulcruming off those posterior interferences. So if I play that again, okay, there's the avoidance, the hit and slide, and now the occlusion and bruxing backwards, okay, and you start fulcruming on that posterior tooth. So let's go over a definition of maximum intercuspation. It's the complete interdigitation of the opposing teeth independent of condylar position. This was our old definition of centric occlusion. So as they taught us in dental school, what our goal is try to make centric occlusion or maximum intercuspation equal with centric relation. So this way, that as the teeth come together, the condyles are seated in the glenoid fossa, the muscles are working in coordination with each other. Here's some schematics that I'd like to thank Montage Media for allowing me to use. But on the left, we see a situation where we're in maximum intercuspation, but the condyle is not in CR, it's down and forward. By using any methods of centric relation, whether it's bimanual manipulation, a leaf gauge, or an anterior deprogrammer, which we'll be talking about later, as we seat the condyle, we see that a posterior tooth is what the interference is. That's the fulcrum. Now, obviously, you see in the anterior region, our vertical dimension has increased. Now, have we necessarily increased vertical dimension? Not really. What we've done is we've gotten anterior room to do any type of restoration, okay, and we've not necessarily stretched the masseter muscle, which is at the ramus, okay, and that's responsible in growth and development for our vertical dimension. So here's a situation that applies to lots of attrition and worn cases where you look at the case and you say right off the bat, I have to open up vertical dimension to gain room for restorations. This diagram shows you, by just getting the condyles back up into CR, how much room you can gain in the anterior region for your restorations. So again, if we build a crown or we have an occlusion that is not corresponding to centric relation, that as the elevator muscles want to pull up and back and put that condyle head into the most superior position in the fossa, that tooth is in the way. And we're getting proprioception feedback to our brain to say, hey, that's a noxious stimuli. We don't want to reside there. That doesn't feel good. So that the lateral pterygoid muscle now is going to contract to try to avoid that tooth in closing. So you have one set of muscles that are pulling up and back, and you have another set of muscles that are pulling down and forward, and this is the prime example of muscle and coordination. What Frank Spear says in his seminars and manual is that centric relation is not about putting a patient in a specific position. It's about eliminating what is preventing the condyles from going there, which is namely the inferior belly of the lateral pterygoid and back teeth that are built that in not corresponding to centric relation. So again, people give centric relation a bad name because they tell you you're manipulating the patient back there, and that's not true. All you're doing is seating the condyles where they're supposed to be and then getting rid of any of the interferences that will prevent the condyle from going to that position. The big question as restorative dentists we all have is, in our practice, in our day-to-day general practice, where do we restore a dentition? Okay? Do we use centric relation or do we use habitual closure? Well, as a clinician who practices, 4 or 5 days a week, I don't use centric relation all the time. I use it on my large cases, I use it on my full mouth cases, but one of the first things that I want to look for is signs of instability. Is the masticatory system stable, or are there signs of instability going on? And what are the signs of instability? Well, if you have TMJ pain, if you have muscle headaches and muscle pain, if you have severe wear of the teeth, are there mobility? Are the teeth loose? Are there abfractions? Are the front teeth, are the edges chipping and wearing down? Do we have a lot of gingival recession in some of the areas and have those class 5 abfraction lesions going on where the teeth are starting to micro move? If those things are going on in a case, okay, then we realize that that's not a position that we want to restore to. So here's a photograph of a destructive bite, and this is somebody who's a big-time bruxer and clencher and lots of gingival clefting and abfractions and wear. If we're going to restore this mouth, do we want to restore the dentition back to this position? Obviously, it's not working in his natural teeth, so if we went ahead and put porcelain on these teeth, what's going to happen? The porcelain's going to fracture. Again, I said that I don't use centric relation on all my cases, nor do I go ahead and equilibrate everybody to centric relation unless I see signs of instability and there is a problem going on. But habitual closure is what we use in most of our single units, in the practice. I use it on asymptomatic occlusions and if we're doing limited restorations. But one thing you want to be aware of is utilizing habitual closure when you're doing second molars. And everybody who's probably watching this video has all had the same situation in their practice where they've done a crown, they know they have a great contact, and it's usually 2 or 15, and they put the crown in, everything is great. The patient comes back 6 months later for their hygiene recall. The hygienist comes into your office and says, I have Mr. and Mrs. So-and-so here, and there's a large open contact between the first and second molars. And then your heart drops and you go in and you see that you can drive a truck through there, and you know when you put the crown in, that wasn't there. So if we play this back, we can see what's happening is that we put that crown in a position that was a prematurity. It was an interference to centric relation. So as the patient clenches or bruxes, they're driving that tooth back. The other situation is when we go ahead and put a crown on a back tooth. Okay, now, how many people out there you know that you've prepped a second molar, you know you've taken 2 millimeters off the occlusal surface, you ask the patient to bite down and you don't have any clearance. Okay, what's happened? Well, basically, that was the prematurity that you prepped away. Now the condyle on that side is able to seat further superiorly in the glenoid fossa, and now you don't have any clearance anymore. So this diagram is showing you on the left where habitual closure was, where you prepped the tooth to, but once that prematurity was taken away, now that condyle was ready to go back up into the most superior position, and all of a sudden you didn't have any clearance anymore. So just be careful on second molars, because you can be taking away the prematurity, getting more superior seating, and then have a problem with the new restoration you just put on. Also, if you put a crown even on first molars or bicuspids, that if you take away a prematurity or actually add a prematurity to your new restoration, then what's going to happen is you're going to get a hit and slide. That the brain knows that they don't want to reside in that area where that high point is, and they want to avoid it. So that they hit that tooth or they hit the new restoration, and the lateral pterygoid pulls the mandible away from that, and actually you get this hit and a slide forward to it. Okay? And Pete Dawson talks about this all the time and shows it in his center, where you do bimanual manipulation. You find the first point of contact, you ask the patient to squeeze tighter, and then you can actually observe this anterior hit and slide. How many times do we put crowns on teeth and the patient comes back and they said that they're sensitive? Okay? And then the first thing is, well, it'll go away, maybe it's the acidity of the cement, and after 2-3 weeks they're still calling up and they're saying they're sensitive. And for the majority of dentists out there, they probably make the next call to their root canal specialist. Unfortunately, a lot of times or most of the time, it's occlusion. Okay, and you can have the patient tap, tap, tap on articulating paper. You don't see anything, but once you put them in centric relation, okay, and put the articulating paper in, all of a sudden you start to pick up marks on that tooth that you didn't see in habitual closure, and somehow they're finding that contact when they're sleeping or they're bruxing their teeth, and that's what's making the tooth sensitive. So if you learn the techniques of having to find the first point of contact, which we're going to go over later, you can eliminate that interference and hopefully get rid of that hypersensitive tooth. So why do we want to use centric relation? Well, it's reproducible. Okay, it's a great starting point. In dental school, when we did dentures and we didn't have any teeth. Okay, it's the same thing when we're doing reconstructions. You want to have a repeatable spot that we can take our bite records to. And you can take that record today, and you can take that record a month from now. You can always find centric relation. Okay? If you build an occlusion that's corresponding to centric relation, you don't have any interferences. Okay? The back teeth are not going to be hitting until that condyle is up into the most superior position. Multiple teeth can be paired at once. You can do full mouth cases and wipe away all your posterior contact as long as you know how to find centric relation and take a face bow, and you can build all your posterior occlusion in. And centric relation can basically be used on all patients except the select few that have a true intracapsular or joint problem. And these guys are my true friends, George Kirtley, Kenny Hamlet, Mike Apper, Alvin Neff, my partner Gerard Lemongello, and Dean Bafiatis, who unfortunately we didn't have a picture of. But these guys are all the senior instructors, and they're a great group of guys, and I think it's a phenomenal program that we put together. So moving on, what we're going to talk today about is condylar position, but more specifically centric relation. And what is centric relation? Well, there's a study that was done recently where at 7 dental schools, when they polled the students and the instructors about the definition of centric relation, that there was so much confusion that they couldn't get a consensus on what centric relation was. So how can they really find or record centric relation? What Pete Dawson says in his book, and this is his definition that we got out of his book, is that centric relation is the relationship of the mandible to the maxilla when the properly aligned condylar disc assembly are in their most superior position against the eminentia, irrespective of tooth position or vertical dimension. At the superior position, the condylar disc assembly is braced medially, thus CR is also the most midmost position. A properly aligned condylar disc assembly in CR can resist maximum loading by the elevator muscles with no sign of discomfort. And, that's a pretty big definition, so what we try to do is break that down, and what Pete is basically saying is that centric relation is a joint-based position, that you can find this independently of the teeth. Okay, you can find at any vertical dimension, and the teeth do not have to be in occlusion, that it's a bone-braced position, and it's a repeatable position, and that's important, to be able to find this position over and over again when you're taking your bite records. It's a physiological endpoint. The jaw doesn't always function here, but it needs to be able to go there freely, and the only way that it can go there freely is through coordinated muscle movements. And what do we mean when we talk about coordinated muscle movements? I'm going to show you a little bit later that we have our elevator muscles and we have our opening muscles, and only through smooth coordination of those muscles can we get to CR freely. Now, what I did here was take my old dental school skull and with some articulating paper, putting the condyle in, showing where the condyle should seat. And basically, you can see that the medial pole is what is braced against that